Okay, just to begin the talk, and the topic was given to me was general endotracheal anesthesia. Is it a vanishing art for sections? I guess the answer is yes. And in next 20 minutes, we'll discuss what are the implications and what are the problems which we are facing. Now, when we talk about general anesthesia in obstetrics, obviously our prime focus is on the extent of lower segment cesarean sections or incidence which is taking place all over the world. Now, these are the various figures which we have. This data is from 1998 to 2000, and you see that most of them have exceeded what the WHO has recommended as 15%. On the contrary, when we talk about 2007, have we really gone ahead and come down on the section rates? I guess it's not there, because China has already exceeded the number of sections done to almost 46%. And rest of the countries, even India, you find that all of them have exceeded the number of sections which are being done against the recommended rate of WHO. Whereas, let's talk about JIPMER, because I have the data from JIPMER which I will be telling you. We are still having a rate of 16%. However, in 2010, if we talk about these recommendations, the section rates have already reached epidemic proportions. We were talking about 15%, and there are countries which are already touching 30 to 40%. So needless to say that the problems of anesthetizing more and more obstetric patients is arising. Now, I'll just like to tell you the retrospective data which we have collected from JIPMER for a year. That is from 2009 to 2010. In this tertiary care hospital, we end up performing about more than 16,000 deliveries a year, almost 1,400 deliveries per month. And out of these more than 16,000 deliveries, 44.7 deliveries are done, or there are operative interventions done on them. Out of these, only 16% are taken up as sections. So they are well within the norms of what WHO has recommended. Now, what do we have to say about this 16% of LSCs? What do we do to them? Well, in JIPMER, if you see, we have about 2,610 deliveries which were conducted in 1 year under lower segment section, out of which 85% of them were done under regional, and 13% were done under general anesthesia. There were 2% where a combination of regional and general anesthesia were used. Now, where do we stand as a tertiary care hospital in India to the rest of the world? When we talk about United States of America, it was about 15% general anesthetics were given to sections, but I think the rate now has dropped down to almost 1%. Australia, it's around about 12%. So we have seen a remarkable decline in the number of general anesthetics which are given to obstetric patients, and majority of us, for obvious reasons, are opting for regional techniques. Now, talking about general anesthesia, when we talk about our institute, we find that GA has been given as a first option in only about 10.5% patients. And in about 1.9% patients, or a 2% patients, because the regional had failed, they had no option but to give a general anesthetic. So the overall incidence, if you take here, is about 12.8%. And if we talk about the combination of two techniques, we found that inadequate spinal level, we had 29 patients which had to be converted to general anesthesia. 4 patients with incidental surgeries like incisional hernia repair and other things, they had to convert again back to general anesthesia. And because of unstable hemodynamics, intraoperatively, they had to intubate, and in these 6 patients, which were later converted for giving general anesthesia. So the overall rate in what we have in this tertiary care hospital is again about 15% of general anesthetics are given to the cesarean sections. What's the worldwide prevalence of general anesthesia in sections? When we talk about emergency sections, which means that there is an immediate threat to the mother or to the fetus, the anesthetists usually go to opt for a general anesthetic in about 41% patients. However, when it is an elective section, the GA rate remarkably comes down. It comes down to about 2 to 10%. And when we talk about the recommendations by the Royal College, the audit book says that GA should be given to less than 15% of the mothers who are undergoing emergency cesarean section, or when it is an elective section, the GA rate should be less than 5%. Now, the normal indications for general anesthesia, which is given in most of the books, are these: that there is a patient refusal, there is a presence of an epidural already there, and so they continue with the regional technique. Specific medical conditions which precludes the regional anesthesia, and there is an immediate threat to life of the patient. Now, what are the prevalence in JIPMER? We have done about 285 cases in 1 year. And we find there are 3 major conditions: the fetal, maternal indications, and the anesthetic indications. When we divide them, we find majority of the indications are because of fetus, that is 46.6%. Maternal indications are about 42.5%. And the modifiable indications, that is the anesthetic indications, are only about 11%. In fetus conditions, we find that it is primarily fetal distress. In maternal conditions, you find that it is preeclampsia, eclampsia, hemorrhagic conditions in the mother, some other coexisting factors like HELP, heart disease, and there are about other patients who have severe anemia, ITP, post-polio residual paralysis, and patient refusal. And of course, the incident rate is only about 20 out of 285 where the spinal had failed. And in 11 patients, they were not able to give spinal despite attempting 3 to 4 times. When we compare these prevalence, what we have seen over 1 year in our institute, to the rest of the world, we find that in UK, the majority of patients who are given general anesthesia are because of patient refusal, 20% of them. And the failed spinal incidence is fairly high. Almost 22% of patients had failed spinal, and that is why GA was given to them. Whereas the failed spinal incidence in what we have in our institute is about 2%. Now, what's the major concern? What are we trying to hint at? We have seen there is a global decline, and there are certain indications where general anesthesia is the only way we can come out. So what we saw in 1982 by a study published by Johnson is that 76% incidence was there to give a general anesthetic to a cesarean section. Whereas in 1982, as far as the NHS maternity statistics go, it was about 50%. Now in 1998, from 76%, this has dropped down to 7.7%. And there in 2006, from 50%, it has dropped down to almost 5%. Whereas in JIPMER, we are still having a rate of about 15% of general anesthetics which are given to the patients, probably because of the patient conditions which I have just mentioned in the previous slide. Now, this is one graph which is published again in Johnson's article. He says the number of trainees which are there have actually gone up over years. But there is a substantial decline in the number of general anesthetics which are being given by these trainees, to an extent that almost a mean number of 5 anesthetics would be given by a trainee in anesthesia. So what is the scenario as far as India is concerned with the US? And I'm taking Dr. Bhavani's data to this. It was an abstract published. And it said that GA for sections by the CA3 category residents, which are going to pass out, was less than 5. And almost 13% of the residents who are qualifying out had not given general anesthetic to a mother. The number of deliveries here, just make a note of it, it is about 3,000 to 5,000. I may be corrected because I think it is somewhere around that figure. Now, what do we do in India? What is happening? postgraduate medical students or MDs, the third year postgraduate, you find that they would have given almost 120 to 150 GAs, right, at the end of their training session. The number of deliveries is remarkable. It is 17,000 per year. Although the percentage remains the same. 15% is what we had, 15% is what the Western world has. But 15% of 17,000, and that is 15% of about 3,000 deliveries. So that's why the major chunk or the training probably in India is a good sign, it is a good hope that because we have so many deliveries, we conduct about 16% of sections, and out of which we give about 15% general anesthetics, we are still able to impart better training to our postgraduates. What about the data in Australia? They published a data saying that a junior trainee would do about 5 sections per year, while a senior trainee would supervise about 20 cases. Number of deliveries is about 5,789 as compared to 17,000 which we have. Number of sections which were done under general anesthesia were about 141, almost less than half what we have done in JIPMER. This figure which I have taken, the average number of GAs were actually taken as a response sheet from all the three years of JIPMER trainees, and they gave us a pro forma filled back, and we give a figure of about 120 to 150. Now, the problem is if you are not trained in giving general anesthesia to a pregnant mother, what are you losing? Why are we so concerned? The concerns are that the trainees would not be trained in such kind of incidents or events which they must know at the end of at the end when they qualify as an MD student. What is the solution? Can we change our practice to impart better trainees? I would just like you to focus on this Cochrane analysis. This is a review which was published in 2006. The objective of the study was to compare the effect of regional anesthesia and general anesthesia on maternal and neonatal outcomes. What was their conclusion? The conclusion was that there is no evidence in this review to show that regional anesthesia is anyway superior to general anesthesia. In the crux that there are similar maternal and neonatal outcomes both with regional anesthesia as well as with general anesthesia. The only thing which they found different was that the incidence of nausea, vomiting was more with regional and incidence of shivering was more with general anesthesia. But as far as the blood loss is concerned, they did not find that there was any difference in them because it did not reduce the need for blood transfusions. So that was the only minor difference they focused on. So considering this review, are we in a position to change our practice? The possible solutions which if I may say is, yes, they also said that more women who had received general anesthesia for C-section would prefer a general anesthesia when they come for second C-section. There is no difference in RA. So should we choose more of general anesthetics for our patients? How can we choose? Shall we motivate our patients by carefully drafting the patient information sheet? Or tell them that we would provide better services, consultant anesthesia services when we give them general anesthesia? Well, these factors, in my view, is probably going to take a long time. And this is not going to come because policy decisions from institute to institute varies. From east it varies to the west. So these factors are probably non-modifiable, but we can always think about it if we can probably perceive a change. What are the other possible solutions? Now the better solutions, rather than changing over the trend from regional to GA, would be that India becomes the hub to train foreign medical graduates. You have a postgraduate here who is doing 150 GAs for a section. Maybe that's where we can share our experience in training the foreign medical graduates in obstetric anesthesia. Large number of deliveries, almost 3 times than what is quoted elsewhere, and a large spectrum of patients which come to us when we anesthetize them. And of course, the other one is if you have money and you don't have patience, then you can buy simulators. You have to have a high fidelity simulator to get an obstetric anesthesia. Or if you don't have a high fidelity simulators, as we had earlier listened to the talks, we can always go for difficult intubation scenarios and cricoid pressure trainers to give our trainees some knowledge or some training about these patients. Now, even if you don't want to buy trainers, you can have simulations by a role play method. That is, a staff can lie down and mimic convulsions, or you can have a protocol for an obstetric hemorrhage, how they will go about and manage it. These are the simulators which can be used. You can actually have different kind of scenarios which can be depicted here, and a student can be trained on it. So simulation can be performed. Now, I would like to focus on training in India. How and what happens here? What's the spectrum of diseases which we have? I'll only give you one case report, which we just managed 2 weeks back. This is a patient who has come to us, 93 centimeters, weighing just 13 kgs, fully developed sexual organs, no pubic hair, age is 30 years and is unmarried. The social implications, she didn't know, the parents didn't know that she was pregnant, and just lands up into the labor room with pain in abdomen until the obstetrician saw her and said, no, she is full term and in labor. They were shell-shocked. She would not reveal anything. No history could be taken from her except what was her last meal. That's all we could talk to her. They were totally shocked. Now, in such condition, when the indication is obstructed labor, impending uterine rupture, because the CPD is so severe that she cannot cannot have a normal vaginal delivery. Last meal time which she told her was about 4 hours. Now, this is a patient which has come to us, and we are faced with a scenario to give general anesthesia to such a patient which we have not even thought of in our wild dreams, which we would not even have read in our books. What to do with them? What I could presumably see in her was that she had a small mouth and potential difficult airway. We looked for a small BP cuff. We were able to get one from another OT. And if you see her ears, they are fully developed. The soft tissue which Dr. Bhavani was telling you, yes, they are fully developed and good, except for the skeletal system which was limiting in her. We didn't find any other abnormality in the brief period which we could examine her. What we did was, we gave her GA. She delivered, this is a child coming out of her, which was about 1.41 kg, preterm child. And interestingly, her ovaries and the uterus were normal. There was no abnormality detected on the gross examination. But during the brief time which we had to do a physical examination, what I noticed was this. When I put the probe onto her fingers, I saw that the fingers are small and broad. They're not slender fingers like a small child. In a child, you will preferably have longer and slender fingers. Her fingers were broad and short. And the ears were normal in size. The mouth was small. So if you look at the tube here, just focus. I had put in a 5-size tube, but there was a huge leak. I had to change over and put in a 6-size cuff tube. Now, when I put in the cuff tube, I had to significantly withdraw it out to have bilateral air entry. And this is what I was correlating with, that the trachea is broad but very short. And if I inflate the cuff, I will inflate it on the cords. So we had kept this tube without inflating the tube. The cuff was probably in the cords. And the only indication which I could find was that this is correlating to the size of the trachea, which we normally do for nasotracheal intubations. Yes, we had a little bit of problem. We had to give some external laryngeal maneuver to put in the tube. So these are the challenges which come to you. They come to you suddenly, and they come to you with an urgent problem that is a constant threat to the mother and the neonate. And there is very little time to assess and prepare. And that's where training plays a major role. If you're not trained well, you cannot foresee what is going to happen and then land up into a catastrophe. So my conclusions are just this. Comprehensive assessment should be a part of the training, which gives you only 5 minutes sometimes. You should be well trained in airway management because the incidence is 10 times more than we see it in the non-pregnant patients. You always give G8 where there are serious life-threatening problems. And you land up with much more complex situations to deal with. Thank you very much.
Many thanks, Dr. Kundra. I know it's lunchtime, but